moving toward Medicare for all? Well, Medicare for all is simply another variant of how do we move to universal coverage and how do we pay for it. So a few factoids on universal coverage. So under the Affordable Care Act, we've been able to decrease by about 50% the number of people who don't have insurance. So among those who have a behavioral health condition, we've gone from 31% uninsured to about 16% now. That's about a 50% reduction. But still leaves 16% uninsured. Well, the same is true in other fields. So we haven't been 100% successful. In the state of Massachusetts, where they've had universal coverage for 10 years, and so unlike the Affordable Care Act, which is not universal coverage, they've actually had universal coverage, they still have 4% of their population uninsured 10 years after they've created universal coverage. 3.5% of that 4% are people with behavioral health conditions because they're the hardest to insure and the hardest to keep insured. So there's, I think, huge opportunity for us to do more in getting a bigger portion of this population actually covered. Now, whether Medicare for all is the best model or modified Medicare for all, because Medicare is pretty much a medical model system that doesn't do much of what I've been talking about here today. It doesn't do the links with social services and so on. So if we're going to move toward that model, I think then we need to modify it in a way that makes it more adaptable for the kinds of populations who actually will be covered, which in our case will be some of the most difficult people to cover we haven't been able to reach in the first place with the Affordable Care Act. So you need to stay on top of that and see, what the various politicians are saying about these models and how adaptable those models are to what we need to be actually focusing on.
You said something about 75% of behavioral health patients are seen in primary care, but only 5% of behavioral health providers are there. And that made sense. But then you said something that I didn't understand about fear of losing behavioral health providers to.
Oh, okay, I understand. Okay. So the question was, 75% of all behavioral health care occurs in primary care, 25% occurs in behavioral health care, but less than 5% of behavioral health providers are in primary care. So as we go forward and we move to the world where it's going to be 90% in primary care and 10% in specialty care, I said we need to be concerned about losing our providers into primary care as the numbers swell with behavioral health conditions in primary care. And I would say that's absolutely true. And the classic example of that would be federally qualified health centers that get a premium in Medicaid compared to behavioral health. So for every dollar we make in mental health, they make $1.06. Now, if I play that out 1 billion times, over 1 billion times, you see it has huge implications. They can compete. They have better resources to pay higher salaries and so on. We need to be concerned about losing our providers into that sector, basically, which is what I'm saying. I'm not offering a solution, I'm stating the problem. And we need to figure out a way that we can provide a better career trajectory for our workers in behavioral health. This whole topic of human resources, you could have a whole conference on human resources. In my opinion, we've gone from 10 years ago, human resources was a problem, to today, our human resources is a crisis. The baby boomers are getting ready to retire. And when the baby boomers go, the baby boomers have run everything. They've run the state agencies, they've run the county agencies, they've run the community mental health centers. They're going to leave en masse. They're leaving en masse. The next generation was what we call the baby bust generation. There are very few people there in behavioral health because they didn't come into the field when Ronald Reagan was the president. They went into business, they went into other fields. Then we have Gen Xers, so the next generation that will take over in behavioral health from the baby boomers is going to be the Gen Xers. The Gen Xers have never had any leadership training. No, I'm serious. So many years ago, the National Institute of Mental Health used to offer leadership training, and they also had grants for leadership training. I can go to a room like this and say, how many of you people have had a grant from NIMH? And a huge number of hands would go up. If I asked that question today, it would be virtually no one. We haven't offered leadership training for 35 years. So if you've always been the deputy and then you wake up one Friday and your boss says, I'm leaving in 2 weeks, are you prepared? How much do you know about Medicaid? How much do you know about children's services, elder services, all these things that you need to know? It's a huge issue for us. And we actually did have a national strategy on human resources that was ready by about 2005, but was never implemented. Now that issue is much more urgent, just much more urgent for us, basically.
Good morning, Dr. Manderschied.
Oh, you're over here, okay, good.
Jeff Ring, I'm a health psychologist here in Los Angeles, Health Management Associates. I very much appreciate her leadership and her comments today, and I resonate particularly to the social influencers of health, how 14 years are lost due to depression, housing, education. The next natural question, I think, is how many years are lost due to the poisons of racism, sexism, heterosexism. We know about African American women and breast cancer. We know about motor vehicle accidents and substance abuse in our American Indian communities. We know about terrible access and quality of care for transgender patients. So I'm hoping that you will agree with me, especially in Washington, D.C., that we need to name racism with a loud and strong voice. We need to prepare our healthcare systems to be able to take on these realities with morbidity and mortality in our patients' lives.
Yeah, absolutely. And I think the purpose of the understand that is to go after some of these things. So it isn't simply to go after poverty, it's also to go after some of the other health determinants, one of which is racism. It can be community racism, it can be institutional racism, it can be structural racism, so on. We need to unravel these things and recognize the tremendous impact that has, even upon the most successful people in minority groups. That has a huge impact. I see that in students that I have at USC, basically, how they've been influenced by that, and how important that is. So I agree completely with what you're saying.
Dr. Manderschied, we've got a question over here.
Where are you? Here. Oh, okay, good. See you.
Good morning, Dr. Manderschied, and thank you so much for sharing all of your knowledge with us today. I agree with you on how behavioral health needs to work closer with public health and adopt their policies and vice versa. So I would like to see if you can expand a bit on your thoughts on how can we accomplish this.
Okay, so let me tell you what SAMHSA and the American Public Health Association have been doing. So over the last 2 or 3 years, as part of the annual meeting of the American Public Health Association, there have been joint efforts between the mental health section in APHA, the ATOD, alcohol, tobacco, and other drugs section, the social work section, to have that conversation. And there's several things. One is working on the standards for public health departments in counties. So a number of years ago, I was on the Healthy People 2020 committee, and one of the health goals we set for the United States was by 2020, we want 50% of the public health departments in the United States to meet basic standards for care delivery. And there were 10 standards that were used to be assessed against. So what we're trying to do on the public health side is to get a behavioral standard into that list of public health standards for county public health departments. There are 1,743 county public health departments in the United States. I think every single county in California has one, and they all want to have that accreditation and certification that comes through that process. So we're trying to modify the process. On the behavioral health side, we actually published a couple of papers in the Journal of the American Public Health Association, which I'll be happy to share with you. And what it basically involves is a form of cross-training where young people, somebody's coming along getting a master's degree in social work, they would also get co-trained in public health, so they would not only know how to develop clinical interventions, they'd know how to do community-level interventions. I actually have students coming up to me these days, which has started within the last few years, saying, you know, I need to have a joint degree between social work and public health. Where can I get that degree? So now there may be half a dozen different programs in the United States where you could go to get that degree. There will be more. And there will be more not only for social work, there'll be more in psychology, there'll be more in psychiatry, and so on as we go on. So it's a problem that needs to be worked on both sides of the equation.
The very back.
Could you talk a little bit about virtual care?
Okay, so I cited one little example here, Marcy Reese's work on virtual care. So in the blog that I wrote, I said there are several different levels of virtual care. One is the Marcy Reese model. I have a primary care physician and I beam the peer in and I beam the behavioral health provider in virtually. And it seems to me that model is already up and running, may not be very extensive, but it's already up and running. Kind of the second level of that is a totally virtual encounter where neither the primary care provider nor the behavioral health provider are present, but there's a virtual link. And I think that's going to become more prevalent as we move into the problems of staffing and operating services in rural communities. And so we're very interested in extending telemedicine into rural communities. We're very interested in high-speed internet in those rural communities and so on. So that's kind of a second level. A third level would be virtual care without a provider present. And what do I mean by that? There are various versions of CBT that can be done virtually without a provider, and the evidence on that is pretty good, that a CBT without a provider will give you pretty much the same outcome as CBT with a provider. And then I guess the fourth level here is artificial intelligence systems, where a person would work with an artificial intelligence system to set their own goals, set markers for things to be accomplished in a period of time, and the artificial intelligence system would learn with that person and learn the progress they're making, give them advice along the way, and so on, and there would be no provider involved. And I think there are all these levels that are potential here. In this, I think we need to be cognizant not only of the technology, but also of the kind of world we want to end up having. Do we want to live in a world of artificial intelligence? Okay, if we don't, then, if I stand here and I keep talking about this, 5 years from now, it'll be operational somewhere and then it'll gradually expand. We need to take value positions on some of these things. How far do you want to go in virtual care? And why do you want to go there or not go there? So we need to have those conversations. And those conversations are very difficult to have. It's like having conversations about genetics. Nobody really wants to have conversations about genetics. But we need, as a society, to have those conversations, and we need to have them in behavioral health care. I think artificial intelligence systems are more applicable to behavioral health care actually than other fields because Our field is pretty much an interpersonal, talking, thinking type field where artificial intelligence would seem very adaptable, basically. So I think we need to think about that, and I think we need to have discussions about that. Okay.
Hello, I'm over here.
You're over here, wherever you are. Over here,
Right.
okay, there you are. Okay.
Thank you very much for that talk, and I'm definitely with you with this dream and making integrated care come to fruition. So my question sort of alludes